This is Module 8, Non-Coronary Cardiac Imaging. Shown here is a single slice through the mid portion of the left ventricle in a patient who had retrospective cardiac gating, and then allowing reconstruction of the data at multiple portions of the cardiac cycle and displayed on a modern workstation in a cine-angiographic mode. This allows us then to look at left ventricular function, right ventricular function, dynamics of valvular opening, and also look at size and characteristics of atria and other external coronary structures. This particular patient has early diastolic relaxation noted in the interventricular septum. When we originally started to do cardiac CT, we did not have the ability of modern coronary and cardiac workstations for analysis, so we had to acquire the images in the standard cardiac short and long axis imaging. However, today with multi-detector CT and modern workstations, we can acquire a series of transaxial images and then manipulate them into any viewing plane using modern workstations. Shown here is a long axis and a short axis reconstruction in a patient who has a transmural infarction involving the septum, apex, and lateral inferior walls. One can also look at the right ventricle very incredibly using cardiac CT. In particular, it's important to appreciate that the right ventricle in the normal individual is actually larger with respect to end diastolic volume than the left ventricle. Thus, the ejection fraction of the right ventricle is roughly 10% less than that seen on the normal left ventricle. Shown here is an 18-year-old woman who presented with syncope and has known arrhythmogenic right ventricular dysplasia. In this particular instance, the right ventricle is dilated, and there are also evident deep trabeculations within the right ventricle. Both of these characteristics are very classic for the presence of right ventricular involvement. Shown here on the left is a cine-angiographic presentation of a multi-view images demonstrating a patient who had had a previous bypass surgery. In this case, even though this is a single slice, one can appreciate the regional wall motion abnormalities of the left ventricle, and there also may be some regional apical abnormalities of the right ventricle, but otherwise it's functioning normally. The image on the right is of a patient with a dilated cardiomyopathy, which demonstrates indentation of portions of the thoracic aorta with each heartbeat. In order to perform cine-angiographic imaging using cardiac CT, data must be acquired in a retrospective mode where data at multiple cardiac cycles are acquired and then put into individual boxes or phases and then displayed as cine-angiographic information. Using a retrospective mode, of course, there is a commensurate higher radiation dose, but does allow LV and RV function analysis as opposed to prospective gating, which is significantly lower radiation, but then results in little or no evaluation of the left and right ventricle except for gross characteristics. When doing a retrospective gating using multi-detector CT, we are actually acquiring a series of transaxial images from the apex to the base of the heart, and within each of these individual slices we have multiple slices representing end diastole through end systole. Now, importantly, you must learn to display the images in a standardized view. When we do echocardiography, we have standard presentations. When we do nuclear imaging, we have standard presentations. When we do magnetic resonance coronary angiography, we also have standard presentations, and this was originally designed in about 2002 to also include cardiac CT. The preferences are to display the images for overall review using a horizontal long axis. Now, for those of you that are more familiar with echocardiography, this is roughly a 4-chamber apical view. Also, vertical long axis views, for those of you, again that do echocardiography, this is an apical 2-chamber view. And of course, standard short axis imaging at the base, mid cavity, and apex. These type of presentations then allow you to present the data in mutually orthogonal views for total analysis of global as well as regional function. Importantly, from a standard short axis view in the mid-ventricle, the plane for the vertical long axis is anterior-posterior, producing again this orthogonal view, and from the same short axis, a east-west or lateral plane horizontal to the long axis can produce the horizontal long axis view, again demonstrating the mutual orthogonality of these presentations. Here's another example looking at more likely echocardiography with an apical 4-chamber view. When you rotate the probe approximately 90 degrees from the apex from an apical 4-chamber view, you are presented with an apical 2-chamber view, which is mutually orthogonal. If you return back to the apical 4-chamber view, the value of cardiac CT is that we don't have to go to a parasternal view as we do in echocardiography, but mutually orthogonal to this view is also 90 degrees from this a short axis view. One can also present data, if you're more familiar with cardiac catheterization laboratory, in a standard LAO with cranial angulation and an RAO with caudal angulation. These again are mutually orthogonal views. Every available workstation does have the ability to perform quantitative analysis of the left ventricle, and this is performed either automatically or in a series of steps set up by the analyst. First of all, you need to define the level of the mitral valve plane. Step 2 then involves segmentation of the endocardium using automatic edge detection algorithms, which then segment out the endocardial surface of the left ventricle. Step 3 then results in segmentation of the epicardium so that one can look at left ventricular wall thicknesses and muscle mass. And step 4 involves presentation of quantitative results. One can present the data then from end diastole and end systole, and then provide information including even polar mapping of ventricular function using any of the currently available modern workstations. One is also able to develop ventricular volume curves, which are very familiar for those of you that do SPECT imaging and other types of nuclear angiography. The same characteristics, including rates of systolic emptying, rates of early diastolic and late diastolic filling, can also be determined using CT angiography. From these data, one can also then develop quantitative information on left ventricular end diastolic and end systolic volume, stroke volume, ejection fraction, and then also finally cardiac output. Shown here are a variety of standard LV parameters looking at wall thicknesses, muscle mass, left ventricular diameters, left ventricular global end diastolic and end systolic volume and ejection fractions in men and women, demonstrating the reference range, mildly abnormal, moderately abnormal, and severely abnormal. Understanding of these types of values is very important in your interpretation then of the results of the analysis of cardiac function using again any of the modern workstations. Other issues outside the area of ventricular function This is a patient with arrhythmogenic right ventricular dysplasia demonstrating fatty infiltration of the right ventricle, which is very well demonstrated using cardiac CT. Evaluation of valves is possible. At the present time, one can look at valve opening and general characteristics of valve closure using cardiac CT. Here's an example of a patient with a infective endocarditis involving the posterior leaflet of the mitral valve. Data have been recently presented demonstrating that looking at infective endocarditis, comparing transesophageal echo with CT, the sensitivity and specificity is very good with an excellent positive predictive value and a very substantial negative predictive value. However, generally, it was superior to transesophageal, but valvular perforations that were relatively small were not appreciated by multi-detector CT. Here is evaluation of the mitral valve. Shown here in this arrow is pointing to the anterior leaflet of the mitral valve. You can see that this is thickened, and posterior to this you can also see that the left atrium is significantly dilated. One can then display the view of the valve in a typical short axis, and one can also then planimeter this area to get a general idea of the severity of mitral stenosis. Other characteristics can be looked at, including the aortic valve. This is a 64-year-old woman with known mild aortic stenosis determined by echocardiography. There was a gradient and a 1.8 centimeter squared aortic valve opening noted approximately 2 years prior to the CT angiogram. One, of course, can use CT, magnetic resonance, and echocardiography for all of these evaluations. In this particular instance, using a CT, again demonstrating it in a view orthogonal to the aortic valve, the valve area estimated on the most recent examination was about 1.5 centimeters squared. One can also, of course, look at the left atrial appendage. This is a normal left atrial appendage, where over on this image on the right there is clearly a cutoff and a dark area suggesting the presence of a left atrial thrombus. This evaluation is very important in many patients, especially those who may or may not have atrial fibrillation but are undergoing preoperative evaluation for radiofrequency ablation. However, it's also very important that you have to be quite careful. The presence of pseudothrombus due to layered flow into the left atrial appendage in patients with atrial fibrillation can really significantly limit its application. In particular, compared to transesophageal echo, sensitivity for finding the presence of left atrial thrombus is very high. Specificity, moderate. Negative predictive value, that is saying that the left atrial appendage is absolutely normal, is nearly assured using cardiac CT. But unfortunately, the positive predictive value, because of the potential for pseudothrombosis due to lack of enough flow of contrast into the left atrial appendage at the time we begin to take the CT angiogram. This pseudo thrombus can be a significant problem, and many times one is forced then to say we need to send this patient off for a transesophageal echo to confirm the presence of thrombus. Non-compaction of the left ventricle is another type of cardiomyopathy that tends to involve the lower half to a lower third of the left ventricle towards the apex. It's associated with the regional wall motion abnormalities, dilation, and development of what's called dense sinusoids, as demonstrated on these images. Apical thinning and the presence of an apical thrombus following a myocardial infarction is very well demonstrated using cardiac CT. One must use very thin sections and look at relative apparent densities, the density of the thrombus will be, in terms of CT numbers, significantly less than that of the partly opacified myocardium in the same set of images. This is a patient who has severe pulmonary hypertension, demonstrating a horizontal long axis view, a vertical long axis view, and a short axis view. Shown here again is clearly dilation of the right ventricle, significant dilation of the right atrium, and a D-shaped interventricular septum, classic for a severe pulmonary hypertension. Pulmonary embolism outside the coronaries. CT is considered probably one of the best ways to look for pulmonary embolism. This is a pulmonary artery on the right, which is normal with normal opacification. This particular patient, who was evaluated for pulmonary embolism, you can see that the pulmonary artery on the right is clearly dark and consistent with the presence of a thrombus. Again, looking at the overall view of the pulmonary parenchyma using what is called lung windows, you can see in this normal example very normal characteristics, but in the incident patient here, there is clearly not only a lack of blood flow out to the periphery, but the presence of likely a pulmonary infarction related to the pulmonary embolism. Pericardial disease, of course, can be very easily evaluated with cardiac CT. This is a selective volume rendering image looking at the entire cardiac surface, including the pericardial fusion, and then by altering the window and level characteristics, one can remove the area from view of the effusion and demonstrate just the heart by itself. Using a maximum intensity projection from a horizontal long axis view, you can see the location of the left and right atria, but importantly, you can see the surrounding pericardial effusion. Calcified pericardium and constrictive pericarditis can also be easily demonstrated. This particular patient on the left had tuberculous pericarditis. This patient on the right is a very interesting example. Patient presented with all of the clinical characteristics of constrictive pericarditis with the positive Kussmaul sign and other characteristics, but on CT angiography was found to have obstruction of the right ventricular outflow tract due to a calcified pericardial cyst with a normal pericardium. One can also look at other characteristics. Here's an example of a patient who had an aneurysm resection and repair, and you can easily see the presence of the pledgets used by the surgeon to seal off this particular region. Other characteristics: here is a left atrial myxoma that is prolapsing through the mitral valve into the left ventricle. Although one could use a prospective set of images to establish the diagnosis, a retrospective set of data would allow one to look at the dynamics of the tumor moving to and fro through the mitral valve plane. Other characteristics: here is a membranous ventricular septal defect, clearly demonstrated in this particular example on the left. On the right is an atrial septal defect. One can see that this is probably a patent foraminal valley. Importantly, the only way that you can best evaluate this is to have actually less contrast in the right ventricle. So the determination of the jet, which you can see here near the arrow, is best appreciated by the fact that the contrast in the left atrium is greater or more dense than that seen in the right atrium, and thus the presence of the jet. If you had equal opacification, it may be somewhat difficult to actually appreciate this subtle characteristic. Temporal infarct enhancement has been evaluated by researchers at Johns Hopkins, demonstrating myocardial viability, a 30-second, 5-minute, 10-minute enhancement of the apex in particular, 15, 20, and 25 minutes. So an area of the apex which would not appear on the initial examination to have any perfusion, by looking at delayed infarct enhancement, you can see that this region does have clear blood flow to the region. Other characteristics are very important, particularly when you're evaluating a patient for preoperative assessment of radiofrequency ablation. You must also understand pulmonary vein anatomy. Generally, there are 4 pulmonary veins in most patients. 5 pulmonary veins, however, are not uncommon, demonstrating a right superior pulmonary vein, or the more common 5 pulmonary veins with a right middle pulmonary vein. Roughly about 28% of the patients will present with 5 pulmonary arteries, 68% will present with 4 pulmonary veins. A common ostium for the left pulmonary vein can be seen in about 14%. Looking outside the heart, one can also use CT angiography very nicely to look at aortic dissection. Shown here is a volume rendering of a patient with a type B aortic dissection. This is also involving portions of the aortic outflow tract and, of course, the thoracic artery, thoracic aorta. Again, another demonstration of the same situation. This is a patient that also has a dissection involving the root of the aorta. You can see the clear dissection within